everyone listening in today. We're going to base a lot of what we're doing and talking about with Chris is based on our experience going through 2008 recession. And at the time, we had smart lipo. So that's the foundation of this talk, how to help everyone, whether this part and what to offer to your patients in order to be able to accomplish that. So, Chris, thank you for putting everything together, and looking forward to seeing everything.
No, well, thank you, Spiro and Shaq, for taking all the time and effort to get this series going. It's an excellent one, and it's really something that we can take advantage of even before this situation, but you really ramped it up, and kudos to you guys. Anyway, let's get going. This is something that's familiar with some of us very much as plastic surgeons, and cosmetic surgeons, and some not as much. So I think we'll kind of cover all the bases as quickly. Spiro and I are a two-surgeon plastic surgery group here in a major metropolitan area in New York City. We have one Quad ESF accredited operating. We do general anesthesia cases. We do real cases, in other words. We have full-time or 6 part-time employees. We consider about 7 full-time equivalents. But we kept our full-time employees on payroll. Here in America, we have a PPP program. We won't get into that details, but it was helpful in keeping things going and taking care of our staff the right way. Unfortunately, we have seen exactly 0 patients since March 12th, and I believe the governor read it today, said hopefully by June 13th, we'll be able to do elective surgery here in Manhattan. I think other parts of the state are up and running, as our colleagues throughout the country and throughout the world. Kudos, hopefully you guys and gals are operating. All right, elective non-emergency surgeries, like I said, will maybe reinstated hopefully mid-June. We're still restricted, and we had our ventilator prepped and ready to go. It's actually sitting in our waiting area, ready to be taken, but it's off the volunteer list, volunteer like that. So we're gonna, when we're ready, we'll be ready to go. Just as an aside, our carrier allowed one of us to suspend our privileges to no premiums, and the second one went part-time in order to, we're still communicating with the patients. That's still technically a patient-doctor relationship, emails, calls, et cetera, the occasional prescription. So we don't do emergencies and we don't do reconstructive, just as an aside, but still we need to maintain that continuity. As Spiro mentioned, we learned a lot from 2008, 2010. And I think the biggest thing to take away is that it is temporary, and we'll cover it. The tail of the curve will be a little bit more drawn out and longer, certainly, than anything we've seen collectively in our history, in modern history. But I think we definitely going to be ready for the upturn. I think, in our opinion, smaller cost procedure would definitely be more popular. We've seen that trend actually start even when we started doing this before 2007. And it just becoming more and more popular for the reasons we'll get into in a moment. Don't be afraid to return to deposit patients. We returned all our patients. No questions asked. They said, listen, we understand everyone needs to save their pennies. And we already had the deposits back for hopefully June. We have tentative schedule for the second week of June, but obviously that's up to the government institutions. People always want to look good and feel good no matter what the economic landscape is. Spiro, you sent me this, and it's very true. And the multitude of articles, especially on the internet. Basically, we don't like what we see on these teleconferencing calls, and we kind of let ourselves go collectively. And I think there's going to be a pent-up demand, and I think we are seeing that in our consultation intake forms, et cetera, et cetera. We just have to be ready. How are we going to be ready? How do we start? What do we do first? What do our protocols be? All these things. We have a box of quick test reagents for the COVID-19. It's not an antibody test, which requires a blood draw. This is just a finger stick, not unlike a diabetic blood sugar stick. So the specificity isn't great. It's a 20% false negative, but the sensitivity is quite good. So if you're positive, it's good, but if it's negative, it's okay. But it's something that is going to be helpful for A, reassuring our staff, B, reassuring our patients, and then implementing these protocols that we're kind of putting into play real time. In the hospitals and ASCs that require a blood test. Maintain engagement with your patients. Spiro, feel free to jump in. We credit you for maintaining the web presence, the overall presence to the practice online for our patients. Digital platforms will continue to thrive as we all have seen. Virtual consults files are here to stay. We started doing this, our first ones in 2008. We had that television program. You want to expand on that and how the legal landscape has changed dramatically in the last 12 years. More and more video conferences. Do you want to talk about that? I think double down. This is the time to reinvest in our brand. Sure, we were kind of holed up in a cave for the last 6 or 7 weeks, but now we slowly reintroducing our SEO and our other nuts and bolts of our brand presence online. So when we're open, that's up to government institutions. Hopefully most of you all are open, are starting to see patients whether in person or virtually, and what treatments will we perform. Let's talk about, we're not going to talk about fillers. We don't have a huge filler practice, although it's something we don't ignore, and we want to actually augment and do it, but we're still surgeons at the end of the day, that we choose to be, and we want to offer our palette of services to be expanded. We want patients looking for just one price. I mean, in the old days when I was a resident at the turn of the century, all the cosmetic surgeons I followed would have surgeon fee, anesthesia fee, facility fee, and then private duty nursing. Our practice may be different than others, but our patients just want one global fee, and we kind of roll everything into there, more or less. So that's what they're looking for. I think that our patients tend to be on the lower end. It's around 28 years of age. And these smaller procedures we'll talk about later, but they have almost 3 procedures per patient over the lifetime of the relationship between the practice and the patient. So that's important, that they're happy and they come back and they're seeking out other procedures. Many patients will be doing their treatments, pre-sale units. We don't do a subscription program, but those of us, our colleagues that talk to it, it's been very successful for them. In our market, we don't see it as much, but that's okay. Able to treat more patients and still have them masked. So we're going to maintain all the COVID protocols. Not going to say we know it to death. We're going to mask and gown and face mask and all those kind of things. And the non-invasive things that we're not going to get into as much today, like the Evoke, is what we call 2-touch method, where you just set and forget it in the beginning and the end, which reassures the patient staff alike that the 30 to 45-minute procedure will be minimal interaction. So what are the most common treatments that we saw? We're going to see trends later on, and then we're going to really focus on the local versus general anesthesia. I don't know if you can see the cursor, but we're going to see what will the cost tolerance be. We're going to focus on skin tightening is still going to remain the first, second, or third thing that patients want. They either want to give contoured and or skin tighten. No one wants just contouring and not skin tighten, in my opinion. Even the young patients who look great anyway, irrespective of that technique. So large surgery for smaller, more cost-effective procedures. We position ourselves to say, well, okay, well, I can't do 5 or 7 areas of liposuction local. True, but we can also offer them a schedule where they can come back with minimal disruption to their schedule, say 2 days consecutively, and then they take a day off after that, so they're only away 3 days. Or it could be like a Saturday. They still get their 4, 5, 6 areas done. And it actually can be cost effective. We'll get into details and nuts and bolts.
Hey, Chris, let me interrupt you really quick. I think it's an important question. When it deals with lidocaine toxicity, how do you deal with that? And I think that it's really important to point out that local anesthesia, only 1 in 10 plastic surgeons actually do it in the office. So the majority of the doctors doing it out there are dermatologists and all the other specialties, because they can't get office privileges for the hospital. Having said that, that's what patients are asking. So could you break it down for us? A, how do you deal with lidocaine toxicity? B, how do you tell patients that, hey, can you, to do it twice, as opposed to knocking everything out at once? Not everyone has a quad ASF operating room and has the luxury of knocking these patients out. And certainly right now, due to COVID, in general anesthesia, we all know that's a big issue. A lot of people are scared. So if you can guide us through the protocol of lidocaine toxicity, the medical, and also what you tell patients specifically as to why you're breaking it up, and what kind of resistance have you had with that?
Absolutely. I'm going to break the fourth wall here. I'm going to go over here so I can skip ahead. So that's a very good question, but I wanted to address it now.
Get to it when you get to it. That's okay.
Okay.
I mean,
All right.
I just think it's important that we
Great point. That's actually probably a good chunk we're going to talk about today. So they want smaller procedures, faster recovery, avoid taking time off. Now that they're back to work or whatnot, they don't want to be seen as not in the office or not on teleconferencing or not available. They want to be available. So our average return to work is 24 hours or so. So we do a Friday and a Saturday, flanks on a Friday, Saturday, abdomen and chest on a male or something like that. Recover on Sunday and they go out to work on Monday. But we'll keep the revenue flowing, and the patient's daily activities are minimally interrupted. There are added costs. Some providers may not have the ability. It's like you said, not all of us have an OBS. We have to go to ASC, we have to eat peanut butter and cracker sandwiches while we're waiting for the case before us to get on time. Here in the office can be highly efficient, things we don't have to talk about, but it's also cost efficient for the patients. Practice promotion, internet, social media investment, we can talk. I'm going to buzz through this real quick. So I'm going to focus on the minimally invasive. We want to make sure that it's something that is being sought after. We're not just a pie in the sky surgeon saying, okay, build it and then we'll come. Certainly that's one of the aspects of it, but it also has to have a solid foundation in the popular medium as well. And it's kind of a gap solution. So no, it is not a replacement for a tried and true face and neck lift or a tummy tuck if indicated. But if you take 10 patients for an abdominal consult, 6 of them need a tummy tuck off the bat. Of the last 40%, say 1 or 2 will do just okay with regular lipo, but there's those 2 in the middle that we as ethical surgeons hopefully will say, oh, you know what, I'd rather do a tummy tuck on you or nothing. And then if that were the case, the patient say, well, let me go down the street and see somewhere else. They're gonna have a bad result, but that's a lost opportunity for both the patient and you because they're gonna have a substandard result, in my opinion. But if you can have a device that can give you the skin tightening that has the merits in between that of an excisional procedure and a regular non-energy based modality, you want to capture that last 15 to 20% of patients. And then we saw it in the arms case. You know, we were doing the article on arms, and a lot of us will say brachioplasty or nothing. Patient says nothing. They walk out of your office, you've gone out on the street, and you see them a year later and they have a poor result, and you have to end up doing the brachioplasty. Had they had the RFAL, for instance, I think it would have been a great discussion point at the very least if they were a candidate or not, and that's certainly going to be applicable. So we call it a gap solution. Actually, you came up with that nomenclature. I think it's accurate. So it's not a replacement, it's not a substitute, but it expands your demographic and expands your plate of services. So it's a gap treatment for those who are going to walk out your door who don't want the brachioplasty scar, tummy tuck scar, bilateral scar, and those who are going to have a poor outcome by a lesser experienced surgeon. We're not going to harp on that, but bring it up. So ventilators have a negative connotation. So that's a psychological aspect on its own, which has only been intensified in the last several months. And so we're going to really focus on the energy assisted modalities, all of them, but obviously today, radio frequency. This is the platform that we use. There are 3 actual devices. The third one is a small FaceTite, which is 6 cm on the working part. The internal probe is the one that works underneath this sub-Q fat space or within the sub-Q fat space. And this is on top of the skin. And this is the platform, solid state. And I think it's about 40 pounds. If you have multiple offices, you can move it from place to place. No optics or mirrors. So there are disparate temperatures that are goals, which is actually a keen engineering trick. And I have to hats off to engineering, because traditional bipolars, when we do neurosurge rotation or we do hand surgery, bipolars, it's 50-50. It's equivalent energy between the 2 electrodes. Here, there's disparate amounts of energy being applied, roughly 3 to 1 more powerfully on the inside, because the SFS, or as FSN, fibroreceptor network, as Malcolm Paul coined, needs a higher temperature gradient in order to elicit the collagen response that we're looking for, whereas it's too hot for the dermal component, particular reticular dermis. We're shooting for 40 or so in the dermis, but that's not strong enough. Conversely, 65, 70 is too hot for the dermis. So we'll get into that later. But it's a neat trick, in other words, engineering feat, if I may, that they were able to come up with that. And the intellectual property is pretty robust. I think it's a neat picture also provided that shows the dendritic or branching theory. You had the trunk, which is your FSN, the base of your contraction, if you will. And then it's what we like to call bulk heating, because it's a 3-dimensional thing. What's between the electrodes is actually sandwiched between is going to be privy to the energy. It's going to respond to it. Not unlike the tines the metal portions in your toaster oven get hot between the positive and negative of the plug, that resistance will be meted out and translate into temperature change depending on the characteristics of soft tissue, fat, FSN, collagen, skin, what have you, but it's done safely, homogeneously, and efficiently. We don't want to be there all day either, but we'll get into that in a second. Okay, so Spiro, you mentioned this. So lipo is always one or two, basically what we do in the cosmetic arena for plastic surgeons. These are self-selected survey. However, if you see our colleagues that are outside of the plastic surgery field that are self-reporting, these are old data, about 2009, but still very prudent to these days. And about 1 million cases back in 2009, and I think just by rough estimation, it's got to be over 2 million cases annually. I think you may agree with that figure that are done, and the 3 out of 4 liposuction are done by so-called non-core surgeons. Our colleagues have tremendous experience. We have a lot to learn from that. Jeff Klein developed the local anesthesia technique, for instance, back in the late 80s, early 90s. 250,000 cases of these are done in 2009 with some energy modality, whether it be laser, and more recently with RF, but it's associated with technology. So you mentioned 3 things that patients are looking for a doctor. Doesn't change, at least in the last 8 to 10 years. Experience, first, correct me if I'm wrong, Spiro. Second is technology, being an expert in something that is new and creative. And then thirdly is price. So it is a factor, but it's not 1 or 2, which I thought was very interesting. And majority of the laser cases were performed when these data were done under local anesthesia. So once again, like you mentioned, these surgeons were not privy or didn't have privileges at an ASC or hospital within the scope of body contouring for whatever reason. So they were doing these things in the office. They were able to develop the protocols for safe and reproducible things. We'll get into and this brings us to liposuction. We have many safety advisory boards from various societies, and it does mention accreditation. It's all state specific. We're going to gloss over this for a second because I want to get into the science of it a little bit. So there's a lot of RF articles out there, but let's look at the RF under local in particular. And we were privileged to write the CME article back in 2019, January for PRS. So we're not doing anything crazy. And then we also kind of lean back on our experience in the beginning with volume. You can't argue with numbers, as my old professor said. So he said, if you have 10 great cases, not a big deal. But if you have a significant number, you can spot trends, and then you can adjust your technique accordingly to make it safer and better. So and then the morbidity and mortality was very favorable over a long haul. We've done about, I'm guessing about 4,500 cases now, I think this type, over the last 11, 12 years. So we feel comfortable with the technique. So how can we translate that? We've started doing a procedure room. We have an OBS, but basically in New York State, most states in the union, you do not need to be fully accredited for anesthesia. So that makes it very flexible. We looked at this on local anesthesia back in 2011, and we looked at all these things are not been changed. We still go through the full H&P, take good photography, labs when indicated, et cetera, but it's just very streamlined. We do give our meds preoperatively, a little Valium or diazepam, some hydrocodone, and antibiotic by mouth. We have sublingual troches. We rarely use those. We also have the 50/50 nitrous oxide, which is patient delivered. Many of us know this by brand name Pronox. And we may have, they're not NPO beforehand. So let's look at the stages. It's a doc.
Hey, Chris, why aren't the NPO beforehand? Could you mind explaining to us?
Yeah, you do not need to. Actually, we found that our patients should have a light meal beforehand because a PO antibiotics can be a little bit irritating to the stomach and the small intestine. So you can feel nausea, not from anything that you do in the operating room, but from the medications, especially the Percocet.
So how about the patients? Aren't you scared if you accidentally enter the abdomen and puncture a bowel, that then now you have a full intestine?
Good point. Yes. And as a matter of fact, the first number of cases that we did were NPO and had a heplock in there. Actually, Dr. Baker told me once, and you were probably there at the time, he goes, Chris, make damn sure you have an IV in these patients. And lo and behold, first several dozen cases we did, we put a HEPLOC in. So they complained more about having the HEPLOC put in than anything else. And we found that over the course of time, we were able to do it safely from a toxicity standpoint. From a mechanical or misadventure standpoint, say you penetrate the peritoneum or something horrible, a complication like that. In the awake patient, we found that the tumescent anesthesia is an excellent analgesic methodology for the subcu fat skin, but extremely poor for analgesia of the fascia and muscle. Even if you just scrape your cannula inadvertently just on top of the fascia, the patient will jump and they'll tell you in no uncertain terms that they're feeling uncomfortable. If you're in the right plane, you're good to go. But if you violate anything at or below the fascial level, the patient in the awake situation will tell you, which of course, when they're asleep, is not there. Okay, so it's just a doc, the patient, and in our case, we use a medical assistant here in New York State because local case. And it's also a small footprint, the small footprint of the device. We have a small aspirator.
Hey, Chris, I want to interrupt you again. Yep. I mean, a lot of us are surgeons and we kind of understand how the setup is, but I'd like to know why we use this, why use a surgical tech and why not use a nurse? Right. A lot of the colleagues here, might use a nurse in the operating room for a local case. I mean, what are the regulations in New York and does everyone need it? What are the difference monetarily? I mean, how, a nurse is expensive versus a surgical tech, or how does that all work?
So basically in New York State, if you have an anesthesia case, you require 2 RN level people, one to circulate and one to recover. You can use a scrub tech and an MA. And as far as local anesthesia cases, of which this falls under that category, Class A, for instance, Quad ASF, the doctor and the patient can do it by themselves. On the low end of technicals is like sewing up or taking a mole off. You don't need, most of us have a nurse anyway, but if you were doing it laceration after hours on a kid that falls down, oftentimes, in the beginning of my career, it would just be me, the parent, and the patient. So in those regulations vary state by state, but those are generalities. So it's from a financial aspect, at least here in the city, an RN commands a much higher pay scale than an LPN, and then a medical assistant even less. So it can be very efficient.
What is the pay scale for RN in New York?
I think it's, we probably pay in the average to high end, it's about $70 to $100 an hour.
What is a surgical tech?
20 to 35, and then LPN somewhere in between, depending on level of experience, et cetera, but those are general things. So basically a medical assistant is less than half of an RN. So
what you're saying is that could be potentially a big saving to a practice, an additional saving if they're doing local anesthesia.
Yes. So in my last practice, I had an RN all the time, but I was doing a lot of these local cases. So now when we do our general cases, you know this, but most of us do the same thing. We schedule all our general cases as much as we can on the same day. So we have our full complement of the staff that were there for the day. But the rest of the week, we can pepper the local cases here and there because our medical assistant's full time. And it gives us a huge amount of latitude for my office manager to say, Dr. T, Dr. C, or, Mrs. Jones wants to have her flanks and abdomen done this weekend. Can we say, yeah, because we already have someone coming out Saturday. So very flexible. Okay, so this is a modified client solution. It's basically a liter of ringers, 1,000 milligrams of lidocaine per bag. Say, holy moly, Chris, are you out of your mind? That's a lot of lidocaine. Say, no, yes, it is. It's 0.1%, whereas most of us may put in 0 milligrams per liter or up to 400 or 500 milligrams per liter under anesthesia. We still want to respect the ASPS guidelines. We put a little bicarb in awake patients to cut the acidity a little bit, and then we increase the epinephrine by 1.5, by 50% on average, because we tend to use smaller overall volumes, and we'll get that in a second. So if we're going to adhere to the 35 mg per key, if you think of a 70 kilogram patient, that's roughly 2,400, it is 2,450 milligrams lidocaine load that they can have per procedure. So with the concentration of the fluid, it makes the math easy. 2,500 milligrams of lidocaine, I can give 2,500 cc's of solution A, and it makes it easy. And we find that, okay, so if we can only use 2.5 liters of, I'm not going to be able to get through all the procedures like we mentioned earlier. We'll bring them back another day. They're very pleasantly tolerate the procedure very well. They go home, come back. It's much better to have a comfortable patient done safely over 2 days, 3 days, than a patient who is squirrely, having a terrible time, and you're worried about this and that when you should be concentrating on the technique, and they're going to have
Chris,
a negative.
Another question. I want to interrupt really quick. These are the recommendations of the American Society of Plastic Surgery, but in the derm journals, I've seen levels up to 50, 60 milligrams per kilo. And
yes.
a large series of patients. So obviously this is what we recommend, but is there anything we have to watch with the higher concentrations? Obviously these are peak plasma concentrations earlier, but are there any telltale signs of lidocaine toxicity? And what would be the first one that we would pick up on or notice on a case?
Well, it's classic lidocaine toxicity. There's a dose-related side effect profile, right? And patients will more or less experience this. They start to feel some anxiety, and they call it a so-called impending feeling of doom. Then they can have some sort of jitters, the kind of thing psychologically. They can have nausea, vomiting when it gets more toxic, and then cardiopulmonary collapse, obviously cardiac collapse ultimately. But way before that, in an awake patient, they'll usually have a little bit of jitteriness and nausea and vomiting. The peak plasma profiles, as we know from back in residency, varies from 24, 36, and 48 hours. So how are you going to know that during the procedure? So you want to actually follow the guidelines. Yes, outside of the plastic surgery guidelines, it exceeds quite a bit, 35 mg per key. Off the record, you and I feel comfortable going 45, 50, but for purposes of education, we want to posit the ASPS recommendation as the ones to follow. Sure, there was that Italian study came out 10 years ago, said 90 milligrams a kilogram, but that's a faulty study in a very small sample size of, I think it was 10 or 12. And I generally wouldn't do that. I don't think it's worth the effort. And then patients are going to feel lousy next day. Every once in a while, even within the 35 mg per key, the next day, if we can bring them back a second day, they're vomiting. You're probably going to be attributed to a lidocaine sensitivity. It's not a threshold that's 100%. You're going to have outliers who are more sensitive for sure, and outliers who are less sensitive. We can tolerate that, but you want to maintain safe practices. But good question. So excellent safety profile. They're very comfortable, and they go back to work and daily activities very quickly. It's very simple from a practice management. It's very simple. And
well, Chris, you see complete analgesia in immediate post-op period. So with this kind of solution that we're using, how long do you expect them to be numb for? What do you tell them?
So if we finish about lunchtime, we'll say you're going to start feeling it around dinner time, 4 to 6 hours, depending on their level of tolerance as well as their activity. Some people sit still and then they don't do anything. Some people actually, I think people who walk, they might feel a little bit too comfortable. They may end up walking 20 blocks and they shouldn't. They might feel a little sore, but nothing more than like a hard workout. And then we do prescribe them some narcotics and benzo for sleep the first night. Most patients opt to take it for a day or so. And
Chris, I usually tell my patients to take a pain pill or a Valium just before they go to bed at night, regardless if they have pain or not. Because if this usually wears out at 2 or 3 in the morning, a lot of times they wake up in the middle of the night. Yep. That way they get the first night, which is usually a rough night in general anesthesia. It's equivalent. They take the pain pill before they go to bed, regardless if they have pain, and they carries them through the night, and they wake up in the morning, and at least they slept the first night. And I find that to be quite helpful.
Yep.
Obviously, my patients tend to be a little different than yours, but
no, they're the same. Yeah, just I say go ahead and take it with dinner, because they'll have food in their stomach. It'll minimize their nausea, and by the time they go to bed 2 or 3 hours later, they're good to go. I agree with that.
Thank you.
Yeah, and then patient positioning. It seems silly, but if you're doing a flanks, you just side to side. It takes literally 10 seconds for a patient to move him or herself. Whereas if they're under sedation, it's all hands on deck. Anesthesia has to watch the airway, and there's always something that takes a little more, and those are cumulative things. If you're doing a couple cases here and there, not a big deal. But if you're doing this as a significant part of your practice, you want to find efficiencies, and we find that to be very, very helpful. And obviously, we talked about the staff requirements. And there's a huge financial thing. We'll get into it at the end. Okay, here we go with the solution. This is typically what you and I use to make a well-called normal solution. We take out 6,500 practice, we leave it in. We add the equivalent of a gram of lidocaine, whether it be 100 cc's of 1% plain or 50 or 2, whatever the math. Some bicarb. I think we do find it helpful for the first couple liters going in. It goes in much more easily, tolerance-wise, to the patient with low bicarb. And we increase epi because our total volume is not that great. We're not doing 10 liters at 2 mess, and we're doing 3, 4, 5 most. And this yields a 0.1% lidocaine concentration. As we talked about before, it's about 2.5 grams of a load that he tolerate for a 70 key patient. And this is the most common solution. So this is equivalent to about 2.5 liters of volume or so. If you want to push it off the record a little bit more, 3 liters is totally safe to do, but that's within the realm of a personal opinion of each individual, not for the purposes of what we're talking about. All right, so they can another thing. We're all doing high def. Some of us do etching. Take your, if you do an abdominal case, oh yeah, Miss Jones, can you lift your head off the table so we can get your abs to be really contracting? That helps a lot. When they're asleep or under sedation, that muscle tone isn't there. And the marks are great and everything when you do it preoperatively, but if you can have the patient flex on the table, move him or herself this way and that way, it really is helpful for us doing that really fine work. And then we find that it's really more important for the skinnier patients. Spiro gets all the models and actresses, but I get a few skinny patients here and there. And those are the higher, the technical aspects of those are more difficult in terms of getting those shadows and natural contours that we all learn from our colleagues really well. But to execute that when they're asleep, there's a little bit more, more of a guessing game or relying on marks. It takes the guessing right out of it. When a patient flexes their six-pack on the table, it's unequivocal. You can see exactly what
Chris, there's basically saying that you cannot do high def under local is a myth, right?
No, as a matter of fact, I think you and I would agree that it's even easier or more accurate, I should say. And you can have the patient participate, say, oh, take a look here. They're looking at it. And
right.
Yeah, sure, you got 2 messing in there, but we have to explain that differential because we see it as surgeons that we can see the outcome is, but it engages the patient. That's another aspect, non-medical aspect, a psychological aspect of the operation that carries far beyond the operation itself with a positive glow rather than a negative one. Like it also can go south. Oh, we get patients, oh, I had this local case done by so-and-so down the block. I'm not casting stones, but we all have our cases. But if they had a poor analgesia and they're jumping off the table, that's all they remember. It's like, oh, he did a pretty good job overall, but I was just poking me the whole time and it was terrible. That's what they remember a year or two later. So you want to make the whole experience as pleasant as possible. That doesn't sound weird. Patients will tell you exactly how they feel. They're not shy. And you can also stage these procedures. We did a whole series of abdominoplasty patients, and we know that they're in a tummy tuck. But we said, you know what? We're not going to charge you per se for this, but I want to know from my own education, if I suck the heck out of your abdominal pannus, and then I RF your hanging pannus, how much can we get out? So we found when they do this tummy tuck 2 or 3 months later that you can get more give. The thickness of the flap with the lower flap matches better. We all in heavier patients, and you can also get more give. And
Chris,
you have a delayed.
Sorry to interrupt again.
Yeah.
Abdominal. How long do you wait before you stage an abdominoplasty? In other words, if you do the liposuction first under local, and then you do the tummy tuck, or do you do the tummy tuck first and then you do a high def procedure for them? How long you wait in between, and what is the actual way that you break these up?
2 months is the answer, short answer. Whether to do suction before or after depends on what the patient wants. If they're skinnier patients, you would probably be able to get enough of the tummy tuck satisfactorily, and then 2 or 3 months later than that, you can do a finesse high def suction. I'm a chicken. I don't suction aggressively as much as I could do on a table during a tummy tuck. And then the converse is those heavier patients that are apple shaped. You want to debulk them aggressively before the tummy tuck. So you kind of stratify based on that. So you can do it either way, both of them after, but I'd wait at least 8 to 10 weeks for the flap to vascularize more aggressively. Same thing with gynecomastia, brachioplasty. We also do local excisions routinely with gynecomastia and local. They're very well numbed. And revisions. We don't charge, for surgeon fee or revision. There's a small OR fee. So it makes it very practice friendly. So, okay, Mr. Smith she says, he looks great. 2 years later, it says, you know what, I gained a few pounds. I want to take a little more. We'll say, all right, well, if it's something that we agree that doesn't warrant a surgeon fee, they'll have a small maintenance fee. But they say, you know what, since I'm already going for the OR, paying this fee, would you mind doing my love handles? And then what happens, that's a new area. And then you can charge accordingly. And then that brings them back into the fold. So it makes it very practice friendly for the practice, makes it very friendly for the patient to come back. That's why we have about three cases per patient, not 3 areas, but 3 distinct patient encounters over the course of the patient-doctor relationship, at least in our practice, which I think is very helpful for growth. And obviously non-cosmetic applications. All right, so going back to your original question, let's talk about facility certification. That varies from state by state, but if we're going to do general anesthesia or sedation, we need to have certification. Sorry, I don't like this happening. Full-time nursing, we talked about the differences there. The hand fees are disposables. The utilities portion are the fixed cost versus variable, basically. So let's break it down to numbers in real time. So for us, this is an old slide. I think it's about $200 now per case. And we fully gowned and fully gloved. It's up to the individual practitioner. I've been to many offices, and there are excellent docs all around that have variable levels of personal gowns and gloves, and masking. We fully gown as if it were an anesthesia case, but that's just the way it is. This is a representation of our disposable costs, excluding the amortized cost of the device and the hand fees, of course. They're still very reasonable. But let's say if we were to take a typical 3-hour case to our local ASC, which is Manhattan 9 right down a couple blocks away, that's going to cost just in the facility fee and anesthesia alone, even before we charge our surgeon fee, around $6,000. Say the total patient fee is about $12,500, the practice will recoup roughly half of that. Yeah, we could live with that, I guess. We can either raise our fees or negotiate something with the ASC. This is probably on the higher side than many of our colleagues throughout the country, but this is typical for where we are. Let's look at it if we had our own OBS. We can contain our costs because we're not profiting from it, per se. So if we really, between our anesthesiologist and the extra staff and the disposables, it's around $4,000. Then we can recoup maybe 2/3 of our total fee for the practice. So going from a half to 2/3. Now, if we look at our local situation, we're doing the majority of our small body contouring cases, and we just give it about $200 for disposables. And then whether or not you decide to use the RF device, so it's about $500. This excludes advertised cost of machine, of course, but you're recouping for the practice out of that same fee. Remember, the patient only cares about this number, right? They only care about what they're plunking down their credit card or Carrot Credit or Alpheon or cash, whatever. This is the number that they have in their head. This is the number that you're going to have hit the practice after all said and done. There's a significant difference in the profile. So roughly half, roughly 2/3, and almost all of it. Oops. So I think
this is based on how many hours?
3, typical 3-hour case. So 3-hour case, you can do 5 or 6 areas of lipo, right? For, you have help, a PA or a resident, something to slow you down, or you have, like you and I can do cases together pretty quickly. So that, I just took 3 hours as a typical case. So if you have a body contouring as a majority or a significant part of your practice, this is a financially compelling model to actually consider, I think. And for us, we kind of build everything around. And it also feeds your regular practice, your body practice, your breast practice, even your face practice with the Embrace. With Alfredo and Dr. Pittman, we looked at we went down in Alfredo's clinic. We did a comparison of the arms. We weren't going to belabor that, but we found that it was very similar to aggressive superficial Gasparoni style liposuction, is even greater in the contractile properties in a small, albeit in a small sample group. But the kicker here is that it was reproducible and safe. Not all of us can do 1,000 arms in a row super aggressively and not get a problem here or there. I fully admit that I will have a percentage that will be less than satisfactory. But I think the RF, because you want to preserve the FSN and preserve a layer of fat between the subdermis and the internal electrode, that gives you a lot of insurance or peace of mind that you can be more aggressive with your suction, because of the elastic, the properties of the contraction is going to really make it look good. So it kind of dumbs it down, as it were, in a good way. Okay. So just going quickly in a patient survey, what are people looking for? They want to actually have, this is a Survey Monkey back in 2012. 52% wanted to have the procedure in a local, 46% wanted to return to work quickly, and this was wanted a degree of skin tightening. That's where the BodyTite device was entered. But this was just a generic desire on patients in general. So once we got them to have the procedure, how was the experience? So basically, the great majority, almost 90%, 89% had minimal to no discomfort. Every once in a while, you have someone with moderate discomfort, but no one stopped the operation. None had significant discomfort, which is great. And then what was the level of satisfaction after 6 months? Yeah, we want 12 months, but this was for a paper. And we're in the satisfaction rate was 85% or greater. And finally, the kicker is that, so the satisfaction is still satisfied. The kicker here is, would you recommend this to somebody? It's kind of akin to the real self, worth it or not worth it. And 89%, as we know from our crowdsourced surveys, such as Real Self, is a pretty good number. B+ for recommendations is darn good. Okay, so let's get to the device. Here you are with the BodyTite device. This is an infrared image showing, I'd like to bring your attention to a couple things. Is number one, how distinct the treatment zone is, which is great. Secondly, that the efficacy in terms of temperature achieved is good, excellent actually, because anything that's white or greater is roughly 40 or greater centigrade. And then secondly, lastly, it's real time. It's not sped up. This is how you operate, bro. You're pretty quick. So it's also very efficient. So this probably takes about 8 to 10 minutes to do this particular segment. Yes, it does add time to the operation, but it's not a significant amount that's not worth it clinically, number one. Number two, it's done safely because the patients are local. It doesn't extend their anesthesia time. They're not brewing a DVT while you're doing this. And thirdly, compared to the other devices, it's highly efficient.
Chris, I think it's important to outline that a lot of doctors will wait, 10 to 13 minutes for the epinephrine to work after they mess. So during that time, they're either checking other stocks or doing something else. So this thing is so efficient and so powerful that if you're doing a single area, the chances are, the time is not wasted. So correct. During the time when you require for the epinephrine to work and you're heating everything up, it's actually a pretty good use of time. Now, obviously, like you said, if you're doing more areas, the time adds up, no question, but it's pretty fast and powerful. So I think it's important for everyone to understand that.
Yeah, great point. Yeah, Jerry Pittman used to say the hardest part of the case is waiting for the epi to take effect. Okay, so let's just get to the nuts and bolts of it very quickly. If you want to anesthetize it, we just use 1% with a 30 gauge or 32 gauge needle. Just a awake patient, you got a little bit of Valium, a little bit of Vicodin. So you want not injecting, you want to go deep. I mean, it sounds dumb to tell a bunch of surgeons how to inject local, but when you revisit it, you want to inject deep and then bring it out and on withdrawal. And then sometimes you can even pulse it so that it doesn't go all at once, because we all hate TB tests because they're intradermal, and then that wheel intradermally hurts the most. We prefer a 14 gauge needle because it's circular. You could use whatever you want, 11 blade, 15, but in small areas, especially 14 gauges are very helpful. Increase the port size as needed. Use a Stevens tenotomy scissors. You can introduce a blunt infiltration cannula. We use a Wells Johnson 16 or 18 gauge. sometimes a 14 in body cases. It's like barbecuing in the South. You're going to go low and slow. So the idea here is you want to go deep around the SFS, and the purple area means to have analgesia. So you want to go pretty deeply. This is without analgesia. You'll feel a little pop in the trunk, for instance. Patients feel a little pop, but they're not uncomfortable with that, believe it or not. And then you inject very slowly, starting deep, allowing the lidocaine effect to waft, if you will, more superficially. Then you can get the more richly innervated subdermis then covered. The hole should be below the dermis, but you get the idea that you want to get right underneath the dermis very well. By then they already have a level of analgesia, and they're quite comfortable. So let's just watch it real quick here. Natalie, look away. So this is a chest case, obviously. Same principles here, 14 gauge needle. Patient's awake. Yeah, I did staple here, but I did inject here first. I'm not sadistic. And then go low and slow. We're pretty much right above the pec fascia. So video graphic, now with the purple indicating that the analgesia is being pumped in. You go low and slow. You come back, tilt it subdermally. By then the patient has some numbness, and then you can finish off the subdermal that way. And let's go to the next one. Just to show you an arm here, Spiral with an arm case. She's obviously awake, 1% width, tenotomy scissors to make it accommodate the larger cannula. Nice and long, so you don't have to make a bunch of holes. And low and slow, she's giggling. All good. Positive experience and good analgesia. Same thing with calves and ankles, where they're very uncomfortable in the wake. But if you go very, very slowly, it's like watching paint dry sometimes for us as surgeons. But the time actually goes pretty quickly compared to if you have to put the patient under anesthesia, then wake him or her up. It's another 15, 20 minutes to operation. It's pretty much a wash at this point. So you can have a patient in a sensitive area such as this, mons pubis, inner thighs. Those areas are all amenable to a local technique that you otherwise would think would be very uncomfortable. They actually tolerate it very, very well. Okay, let's talk about the RF. Just as a matter of principle here, on just like any gynecomastia case with mechanical disruption, you want to use RF disruption of the IMF if as much as you can at 90 degrees. In the male case, you want to have the contraction mostly in the inferior pole. You don't want the NAC to go up as if you were to do a breast-type case in a female. So we're kind of focusing the energy down there. Same thing, very nice heat signature. The device makes it super easy to apply the energy predictably and reproducibly. Same thing with the embrace here. We're using a counter incision here below a line between the modiolus and the mandibular border, staying away from where the likely course of the marginal branch of the mandibular nerve is. Stopping short. And that's that. And here's just her marks, which happy to go over with off camera with anybody, but that's another time. And we like to bring up a Morpheus. Patients already had their areas done. They're nice and numb. You can really be aggressive with the settings if indicated. And the patients are very comfortable. As a matter of fact, I think you should compensate a little bit for it if you're using the tumescent technique and you're adding a Morpheus as an adjunct. I would actually ratchet up the energy to compensate for the water, because normally if you're just using a topical or a regional block, you're not going to have the tumescent as a heat sink. So I would accordingly increase the energy. But tenets are all the same, the basics are all the same, and the patients are super comfortable. All right, then we just do suction. Patients are very comfortable. We prefer power assisted, but you can do whatever you want. Same thing. Patients are very comfortable. You can see his face over here. So,
Chris, you think there's an element of vibration that patients, just like dentists or something, you vibrate the cheek before you sort of inject local? You think there's an element of vibration that is associated with less pain?
I think so. We learn from the dentist to do, we do an injection, you wiggle next to it. It's the gate theory of analgesia. I might be misquoting that on an anesthesiologist, but if you can stimulate a region that's innervated by multiple different nerve fibers, if a certain stimulation will overtake the gates of the pain fibers, the vibrational fibers will be interpreted first, or preferentially then it's perceived in the brain as less painful. Sure, anything happens. We have that little thing that you buy $10 off Amazon that you buzz on the skin. We stick it in a sterile glove we put next to it, and it works on some people. But I think it's an interesting thing. Yeah, whatever works for you. I mean, all of us in the audience have done tons and tons of injections to this and that. So this is just a takeoff on the things that we already know. So more on the RFAL. This is in 2013. Basically, just because you can do it, should we do it? We'll touch upon other extensions of the technique. BBLs under local, and with Dan Delvecchio, we published in PRS because of what we all are aware of recently in the technical misadventures can end up with a very poor outcome. We want to be very aware of our surroundings and our techniques. So in a nutshell, we want to have same or less, it has to be the same or less risk for complications than the traditional. So is local the same, at least the same, or hopefully better? And it also has to be, in the outcomes, it has to be similar. And it has to be a good compromise. Duh, we all know this stuff, but we have to kind of spell it out. Otherwise, we're doing something that's not as thoughtful as we can. So we want to also have patient acceptance. And then we have to look at, practice management advantages.
Hey, Chris, we have a question before you go in the butt. How
Yep.
much tumescent do you inject for FaceTite? And do you use basically the new, the most popular TXA, it's actually tranexamic acid.
Yeah.
They use it for trauma a lot, but
Yes.
it's becoming very popular now in the plastic surgery literature. Or do you just use the epi for that?
Well, I think the epi and the TXA are for two different indications. I think it's for bruising and that kind of thing, the TXA. Haven't used much of it. I think I did one case when rep sent some for free. I think most importantly, I think it's been proven to be shown safely. A lot of our colleagues that have the privilege of meeting, doing all different types of stuff, they swear by it. And I said, you know what? Would you mind giving me a recipe and I'll try it? And it works great. Patient didn't bruise hardly at all. So I think we're going to make a decision in terms of the cost and whether we have to incorporate it into their informed consent. That was my biggest personal thing. And was that going to be another thing they have to think about when our outcomes are pretty good as it is with the slightly increased epinephrine, we get very little bruising. But I think it's a great drug. I think it works well. If it were free, I think we use it all the time. I think the prices are coming down. We're not associated with the company. I think anything that improves outcomes and then also hastens a patient's cosmetic recovery, among other things, is a good thing. So, and in terms of the epi, I think we have pretty good outcomes with the 1.5 cc's or 1 to 1,000 per.
So how much fluid do you use for
volume
for FaceTite, Chris?
So for those that are not familiar with FaceTite or Embrace includes the lower third of the face with bipolar without suction. And that almost always includes NecTite, which is radiofrequency with suction. So typically 200 to 250, sometimes 300 cc's in the neck. It's like, geez, that's a lot. Yeah, they look like toads when they're done. But believe it or not, when you're done with the bipolar and milking it out in the lipo, they're pretty, and with a good compression garment, they're pretty normalized in 2 or 3 days. And in the lower third of the face, I do another about 20 to 25 cc per size. Like you can do 250 to 350 for the whole lower third of the face and neck. At least I do.
But Chris, how about a patient that has no fat? It's just skin.
Yep.
Can't you just get away with just some local?
Yeah, you can. You can do a couple ways. You can do a combination of regional blocks that we're all familiar with. Neck, not really amenable to that. I would just use a smaller volume. If you're not going to suction the neck, you could put 150 cc's. I think if you go under 120, certainly in double digits, even in those 90-pound ladies from the country club, their neck, they just have inadequate analgesia. So I think another 40 cc's and they have a good outcome in terms of pain is worth it. Then you can milk it out. And if you just bipolar and you just milk out the stuff, they're good to go with 125, 150 cc. But if I almost always lipo even those patients because I want to separate those layers between the skin and the fat. And I think it just drapes better and allows the RF to do its thing unimpeded in a way. Totally anecdotal, worthless to anyone else except for me. But I think it helps things to lay better. But from a quantitative standpoint, 250 to 350 is not unusual. All right, so we can do small, medium, and stage. These are over 2 different days, and large. So this is, I did a couple of weeks ago, a 1400 cc one. So you don't have to limit yourselves in terms of volume under local. Not all patients are amenable to it though. Psychologically, some patients just can't do it, but I find that pretty rare. I would say 1 out of 2 out of 100. There's a nice image that you worked on. We like the DQ position. We learn a lot from Dan Delvecchio, and a lot of these principles are credit to him. But basically, we're staying in a sub-Q plane. We're suprafascial. We're not intramuscular. There's a subject of debate for another time, but for the purpose of today, we're in the fat space, and that's it. You say, well, how the heck do you know that? Well, we know that because, remember, it's a very poor method of numbing the fat, fascia, and muscle. It's a great method for numbing the fat and subdermis. Terrible for fat muscle. So if you're going to poke that cannula into the gluteus, the patient will tell you in no uncertain terms before you can get anywhere near trouble. So that's how we know in awake patients. When they're asleep, I agree. No, I don't. Okay. All right, so thumbs up, right? So this is Pronox, by the way, and she's quite happy having the Pronox. But all kidding aside, the analgesia is quite good. Oh yes, as an aside, for those of us who would know this, yes, we do inject the buttocks with fluid. You say, well, Chris, they're not gonna throw off your quantity, your shape. Yes, to some degree. So we try to mitigate those factors by the following. We'll do an initial pass of analgesia with the tumescent first. So before we suction, do the donor harvesting, we'll do about 2/3 of the analgesia, the tumescent on the butt first, so that A, by the time you get to inject the butt, they have good analgesia. Number 2, or B, some of the saline volume is absorbed, but the lidocaine effect is good. And number 3, that enables us to use less volume overall than if we had to do it all at once right before injecting.
Just to clarify, when you're injecting the butt before you start the operation, you're not tumescing it, correct? You're just putting enough to actually numb up the area, because what's the point of tumescing it? Because you're not really going to do lipo. You just want to get some analgesia, right? So the amount of fluid, at least for my patients, I definitely don't put as much. My end point is, okay, there's no more pain.
Correct.
But I'm not seeking the same amount of volume if I'm doing lipo versus numbing up the patient a little bit.
Exactly right. It's not tumescent. I would say roughly half if you were to tumesce. And for the older folks in the crowd, I would call it like the wet or super wet equivalent, not a whole lot. But given, 30, 40 minutes, by the time you flip her over on her tummy and ready to inject the fat, she's got good analgesia. Then you give a little bit more right before. And then, you achieve great analgesia with less volume. So it doesn't throw off your measurements. Exactly right. All right, that's a nice result from a normal sized person. A little heavier person, only 400 cc's. Okay, some arm pictures, chest, local excision, high def, neck. We can blow through these. Apologize for post-op. Those are sent by the patient herself. Okay, so what are non-factors? Technology is new. Competitor anesthesia has it, and attacks breaks. All these things, sure, they factor in, but they shouldn't be the ones that factor into these are Dan Delvecchio's points. I think they're excellent. Important factors you should consider, I say, you have to agree with the tech. Just because it's the latest and greatest, don't go out and buy it thinking that you're going to be able to market it. If patients are smart, if you don't believe it, they're going to catch on. It's got to be safe and it's got to be effective. And that's that. So any other...
Thank you, Chris. This was very, very informative. If there's any questions right now, we're happy to take them. The bottom line, I think what's important here, you guys understand, is for everyone out there who's resistant to doing local, we can't stress the importance of it. If you have a quad A operating room, of course, you can do either or, but what's important is to be able to really offer the patients as many things as you can. That's the bottom line. So you have to be a la carte. I see a lot of surgeons going blue in the face saying that, no, this is the only way to do it. And you're going to lose that patient. So you can order local anesthesia. You can do it under general. It doesn't matter. Now, if you only have a choice, then you can go ahead with the local. Now, the different states have different regulations. For example, the state of New York, you cannot take out more than 500 cc's of fat, basically, per case. So you have to be smart about it. As far as discomfort is concerned, these patients have no pain. By the time you're done with the procedure, in some very few cases, depending on how aggressive you can get, you can feel something, but the effect is very long lasting and we don't see any discomfort happening. Now, there is a learning curve here. Chris and I we tortured at least 30 patients in the beginning to learn how to do this. And as you do more, you get better. But you want these patients to go out and say, going to the dentist is worse than this. And if you can say that, if they can go out and say that, there's a huge viral component to how this spreads, because not having pain during the injection and during the procedure is critical. A lot of our patients are young too, so they'll tweet during the procedure or, whatever it is, but this has the ability to make it more of a procedure. The view is less of a surgery and you're not compromising the result. So nowadays, because of COVID and the ventilator issue, everybody knows what a ventilator is. Everybody knows if you get on it, you have a 20 to 30% chance of actually surviving. So if they had a healthy fear of anesthesia at the beginning, well, for sure now it's definitely magnified. So being able to offer this to your patients, no hospital, no general anesthesia, in the office, huge thing. And there's two more elements that actually, this is like a social distancing therapy. If you're doing this case with just yourself and the surgical tech and the patient, that's 3 people. You don't need someone to recover that patient. They walk right out. We give them a bottle of Gatorade. So that's one thing. If you have non-invasive devices, which are hands-free, which Chris and I are launching also and pushing really hard now, they come in, they put a helmet on for non-invasive tightening of the face. It takes the nurse 3 minutes to put it on. Then they're in the room alone for 45 minutes. If you want to be nice, nurse goes back in and takes the helmet off and they walk out. So the combination of non-invasive, minimally invasive, no matter which technology you like or which company you're with that you aspire, to work with, or you actually enjoy their technology, it doesn't really matter. Obviously, Chris and I are biased because we've done so much work for InMode, but at the end of the day, you have to offer a minimally invasive solution and you have to offer a non-invasive solution to feed your minimally invasive solution in addition. So those combination of those two is what patients are they asked for back in 2008, and that's what they're asking for now. General anesthesia, hospital cases, they're going to come back, but I don't foresee it coming back strong, at least not in 2020 or until we have a vaccine. So you have to look at these treatments as, we can say easily, phase 1 treatments. So for those states that are opening up, certainly some of these things you can use, a big deal. Chris, we have a question. How often do you use Pronox? Just local and oral medication. Chris and I differ on this, so I'll let Chris answer first.
The oral, which is 10 or 20 diazepam and a Vicodin and an antibiotic by mouth. Antibiotics, 100%. Valium and Vicodin, probably 98%. And a Pronox for me, probably 33%, roughly.
Yeah, for me, so everyone gets a Valium of Vicodin about 40 minutes, half hour before we start, 20 minutes, depending on how big they are. For Valium, I like to give 2 Valiums and 1 Vicodin because it sort of relaxes them, because the biggest fear is fear of the unknown for new patients. So they think, most doctors tell you it is not going to hurt, and it hurts like crazy. So I do give them 2 Valiums and a Vicodin. Everyone gets that. As far as Pronox, I don't use it as often as Chris does. I'll maybe use it once every 10 cases, and that's only because I see the patient might be a little uncomfortable or anxious. And the reason I don't use it as much is because sometimes, at least in my patient population, sometimes they tend to dissociate and not respond to my commands as well. But overall, it's a great tool, and patients really love it. So definitely recommend it.
Yeah.
And as
It's good to
far
have
as
in your back
antibiotics,
pocket. Yeah.
you know, we use antibiotics on everyone. We're old school. Probably shouldn't, but you know, I use them for a week. Chris uses it for 3 days, and it's just 500 milligrams of Delphix.
I wanted to answer one quick question from the audience about tumescent, and one of our colleagues having a little more discomfort from the abdomen, which is very common actually, because it's face and neck, easy to numb. Sometimes the abdomen is getting a little squirrely. I think our workhorse one is solution A, which I presented in a slide. So let's just go over it again. It's basically 0.1%, a gram per liter. And I think this ought to cover 99% of everybody. Anyone, I think that very rare patients that have analgesia is probably mistaking it for anxiety. But the most common thing technically is that we're not putting enough fluid in. So I recommend even in a 120-pound lady, I'll put in 2 liters of fluid easily, which might seem like a lot to most of our colleagues. And then if it's a 200-pound gentleman, I could put like 3 liters in. I mean, really blow up. So I think it's in the awake patient, it's not just a concentration, which is important, obviously, but you have to have a certain amount of turgor pressure so that you have to have enough volume to stretch out the tissue so that the solution kind of can make its way to the nerve endings. Totally inarticulate way of saying it. But if you have a balloon that's only half filled, it's not experiencing the tension from the air as much as you are. Similarly, if you don't have enough fluid in, the subdermis, where it's most painful, is not going to have enough lidocaine touching it, if that makes sense. The fascia is usually the first to get numb, so that's usually pretty good. So the first thing I would do is to safely increase your volume. And if that doesn't work, I think we don't need much more than a liter per gram per liter. We've messed around with 1,500 per liter, even 2,000 per liter, and we found that the difference in analgesia was not significant at all, and it was just way too much lido.
I think,
yeah.
Chris, are you done?
Yep.
So, you know, I think it's important when you have a patient that's going to come in, that if you have your choice about which area to pick for local anesthesia, I always go with the flanks first. Yep. Because flanks, if the patient says, okay, everything bothers me, or, you know, I go with love handles first, because love handles, actually your surgical result is very impressive. So they contract very well, they do very well, but it's also pain related. I found that the pain when you numb up for love handles is less. So it's less painful to do the love handles first. So always pick your love handles first. Second is the lower abdomen. Third is the upper abdomen. So that's sort of the way we look at things. And the reason is the way the fat is attached always also to the underlying fascia and the rigidity of that. So if you want the patient to have a really good experience the first time, and you have sort of the abdomen love handles to do, start off with your love handles. They'll have a great experience. It's not going to hurt. I think what Chris said is absolutely true. Go ahead and put as much fluid as you want in there, and your end point is no pain. Now, I cannot stress that enough. You do not need poudre orange. That's not necessary. It destroys the skin. It hurts a lot and doesn't help you. So to mess, and that will get you through everything you need to do. So love handles, lower abdomen, upper abdomen, that's how the pain, you can stratify the pain accordingly. Now, if you only have to do the abdomen, obviously if you have a patient with more lax skin, we'll take more fluid, but don't be afraid to put more fluid in. And patients who have less laxity in their skin tend to be a little more sensitive sometimes. And there's a lot of variability here, obviously, but it's basically, when in doubt, add more fluid, but try to put enough fluid in the beginning, because what's going to happen is if you don't put enough fluid in the beginning, you go halfway through your case, and now, you know, patient has pain, you have to put more fluid in, it throws off your lipo, it throws off all the numbers, and you're going back and forth. So truth is, if in doubt, add more fluid. You're going to suck it out anyways. You'll be fine.
I 100% agree with that. And as a matter of fact, you can use a more dilute solution. Once you have your initial one, you could use half concentration, because you really need that turgor. And then you just want to spread it out, even because you have a lot of lidocaine there. It's just not reaching the end point. So I think the turgor is very important. I want to just reiterate that. And those of our colleagues that don't do body, a similar flank thing to start with is a neck. Neck is the one, high satisfaction, good analgesia, technically simple to do. And then you can take it from there. And I think you do a 45-minute case once you get used to it. The neck and lower face, patients are happy, you're happy, staff knows what to expect. You can schedule
I
accordingly.
have a question,
That's
Chris,
great.
regarding masks. Tranexamic acid, we don't use it.
No.
How much volume do you infiltrate an abdomen? Well, it all depends on the abdomen, I think, right? I mean,
2 to 3 liters.
2 to 3 liters. I believe we had a question regarding the masks. What kind of masks are we having the patients wear? What kind of masks are we having the staff wear?
Great question. We gave away all our PPE to the city, so we don't have any right now, or a couple masks for staff, but we are back order. So the short answer is, if we can get N95s for everybody, patients and staff alike, great. If not, face shields and regular masks for the staff, and a minimum patients will have masks.
So
we're open. Yeah, I mean,
add to that. Oh.
Again, I don't know. We're doing it by ear right now.
Well, just to add to that, the face shields are pretty. They're not expensive. They're out there, and you can find plenty of them. So if you Google just face shields, that'll get you through a lot of it. Obviously, you want to wear a mask, but if you wear a regular mask and a face shield, at least that's 2 layers. And the face shields are still they're still available out there. You can find them. I believe Yang has some suppliers that InMode works with. She can guide you accordingly for that.
My understanding is that N95 masks are for protecting yourself, and then the regular masks are to minimize spreading to other people, but is not protective from getting it as well as the N95 mask.
Thank you, Chris. I think it's really important, guys, to here's the bottom line. The virus particles will go through all the masks except an N95 and higher. That's it. So whichever way you want to cut that, I mean, that's the bottom line, and we all know that. So, okay, let's see if we have any other more questions, Chris.
Do you want to answer
How long after surgery do you discharge the patient?
10 minutes to get dressed or out.
How much time per area are you heating the tissue, or to what endpoint? Do you use joules or heat or?
Great question. I think that's a subject of another topic because we could talk a long time of it. But short answer is, I like to heat a certain amount of volume of tissue to a predetermined temperature inside and out for what I think is clinically relevant. So for instance, in the abdomen, if I think they need a lot of energy, I'll go 39.5 and 68 or 70. And I'll cook that pizza slice, if you will, area for anywhere from 40 to 75 seconds, and just kind of heating it and maintaining that heat. Because remember, the safety device will cut you off, so you can't overdo it. So you want to maintain that temperature. So sure, if you put your steak in an oven at 475 degrees, you'll sear the outside, but it's not cooked on the inside unless you leave it in for a certain amount of time. So you want to cook the tissues, which is a terrible term, but you want to have the tissues experience energy so you can elicit the response long enough. And I think if you just reach the threshold and then move on, I don't think that's quite enough. You want to heat the temperature and maintain it for anywhere from 30 to 80 seconds in the abdomen, say the neck, a lot less, 10, 12, 15 seconds, face, something like 8, 10 seconds. Obviously,
so
less volume. What do you think is relevant?
The way I look at it, I keep it really, really simple. You want to get to 38 to 42 externally and 60 to 70 internally. If you're not able to get to both of them, at least get to one of those temperatures. That's number one. So the joules become irrelevant, in my opinion. If you want to use the joules afterwards to see how much joules you put for one side versus the other, that's fine. But your endpoint should be temperature. Once you reach that endpoint, the only reason to stay there is to make sure that you got uniform heating everywhere. So remember, if you say, for example, hit 38 and the machine's going off, 3 beeps, it's not transmitting energy anymore. So even if you stay there for 2 minutes, it's not going to do anything because it prevents you from actually, because the safety measures kick in and it's not transmitting. So when you're hearing 3 bells, one after the other constantly, that means it's basically a cutoff. However, it's okay to stay there and make sure you got 3 bells everywhere. And the reason for that is because you don't want to have a cold spot versus a hot spot, and you can get uniform 38 if that was your goal, or 42 depending on what you set it for, and all that. Now, what Chris said, I agree with 100%. You have to be smart about this, especially in the neck. So again, if you have to limit that time, it's okay. Chris, how do you explain high def lipo? What do you think about the fat to transfer after it has been RFED'd? So after RF, would you actually do a fat transfer?
No, NG, no good. The RF will kill the fat. We did that little study, and it does kill the fat. So it's another subject to question line.
Okay,
so Tumes, harvest, RF, and then fine tune your lipoing. So RF after you harvest the fat that you want to keep alive.
Yeah, in my hands, I don't think doing RF after lipo. We find it not to have the same amount of contracture because you're getting a false. Remember, there's no tumescent there anymore. It's very little, so you might get a false elevation. And second, the fibroseptal network is not as tense. It's been deflated, so it makes it harder and easier for get end hits. So as a general rule, if you're going to do a fat transfer, probably a good idea not to be thinking about RF at the same time. Do you ever get neuropraxia post neck garment, use of depressor labii? So any neuropraxias with local in the neck, Chris, or anything like that?
Yes. I think our rate is about 0.5%, like 1 every 200 or so neck cases. And I decreased recently and I thought about this long and hard and talked to a lot of friends about this. And yes, I tend to mess a lot. I think it's a stretch neuropraxia around the course of the marginal branch. And so the things that are favorable, it's got to be grade 1 or less because it resolves in 4 or 5 weeks, thankfully. I don't believe it's a heat injury because we're not anywhere near there, but I think because I'm tumescing a lot below and here, it kind of stretches it out. And I think I'm really not hitting it with my lipo cannula either. I don't believe so. And it's usually unilateral because if I'm lipoing and that kind of thing pretty evenly, I think a bilateral neuropraxia would happen at least once in a while. And in 15 years doing this, probably had 4 or 5, and they're always been unilateral, thankfully.
But Chris, don't you think that if there was a stretch issue with the fluid, you would get bilateral neuropraxia? It doesn't make sense.
I don't know. I don't know
why. I think that, in my opinion, I think what's really helped is the Embrace protocol and going in retrograde like Dr. Paolo Rovati showed us. I think that, seeing across the board nationally, and the number of cases have dropped dramatically with neuropraxias, but you have to technically get under the platysma to cause it. Most of it, I agree with Chris, is a traction injury versus a direct heat injury. And they all mostly come back. So we never, knock on wood, we haven't seen one that hasn't.
Yeah, if it were a heat injury, it wouldn't come back, in my opinion.
What's your experience with AccuTite and jowls versus FaceTite?
Whatever fits. If they got a big jowl, I'll use a neck tight. If they're small, I'll use AccuTite. It's obviously a practice issue also. You don't want to break out 2 disposables for 1 case. And if you want to, you can do a case with a neck tight. Because doing a neck with an AccuTite is a little cumbersome and you have to use counter and punctures and such. So if I'm doing, if I'm doing a case, usually I use one or the other to, just to minimize the disposables. But both are suitable. It depends on how large the area is. That's it. It's just a convenience thing.
Our last question, experience with Renuvion. I've had experience with Renuvion, and I played around with it. My biggest issue is that there's no endpoint, and if there's no endpoint, they don't, where it actually makes clinical sense. We know from 38 to 42 and 60 to 70 is basically associated with other literature out there, endovascular literature for collagen remodeling and collagen contracture. So it's not something that we came up with. So if you're using a device that has no endpoint and you're just basing it on time, how much you have to do it, I think that's actually dangerous. And I think especially the fact that, there's no publications to back up a device. I think that's a big red flag. Chris and I have been doing research. It's on our radio frequency for at this point, more than 10, 12 years. And I would expect if someone's going to use something like that, they would at least have the decency to publish something on it. So flip side is, I know that Renuvion has been used on the face and for facial resurfacing, and I thought that was quite dangerous as well. And I saw a lot of pigmentation problems. We've seen a lot of hypo and hyperpigmentation problems, like an old CO2 laser. And that's probably the reason why it was pulled also from the FDA trial when they went for an indication for that. So look, guys, it's not, obviously we're biased. We like the InMode technology. We're involved with InMode. But, if you're going to look at any technology out there, you need to see some serious publications. You need some serious effort, especially when it comes to energy burst devices, because you can really hurt people. Chris and I, our first 100 patients, we had a 8.3 complication rate. So yeah, we were contracting people. We were having a lot of problems. So we presented that to the company, and as a result, they came up with a device today. And we just finished a study, Chris, that's preparing right now a manuscript regarding the safety of the new device. And it's thankfully we know, what is it, Chris? Less than what the new device percentage-wise of complications?
It's 0.4. So we presenting 300 consecutive cases. So, but the crux of the paper is to compare the first generation device, which only had external temperature, and then a current device, which we're all familiar with, which has internal, external, and a TSP. And among those 186 cases, in 2012 versus in the last couple of years at 300. So it's statistically significantly safer. You could argue where, yeah, we had a lot more time to use it, but I think even getting back onto the horse when it was reintroduced in April 2016, it was safe. We noticed the safety features off the bat, and it keeps you honest. It also makes you appropriately aggressive. We had no idea how hot it was getting internally, but now we have a good range, actual temperatures, real time. It makes a whole the difference in our outcomes as well. Not just safety, but I think we're getting better outcomes. Okay, well, thank you very much for everybody for attending. Chris, thank you for putting this together. Good luck with everything, and thank you for participating today. Appreciate it. Thanks, everybody.